on the evaluation of cervical cancer using ultrasound. Cervical cancer and imaging by using ultrasound. It's a very long story. After 10 years experience in obstetrics, I started working in the gynecological oncology department, and I was so surprised when I realized that uterine cervix could be assessed on ultrasound. Nowadays, it's very common to examine the uterine cervix, for instance, to predict preterm labor, and also to assess the extension of the disease. But in those days, it was absolutely a novelty. In actual fact, even with a not sophisticated ultrasound machine, the cervix is detectable on ultrasound. For instance, this is a very odd image. This is the appearance of a normal cervix. We can recognize the stroma, the anterior lip, the posterior lip, the vaginal wall, the cervical canal. Here, a small cervical cancer is recognizable as an hypoechoic lesion. During the past years, we went on working on this topic in multicenter settings to describe the main aspects of squamous and adenocarcinoma. Then, in collaboration with radiologists, we compared the accuracy of ultrasound and magnetic resonance in assessing the tumor diameters and in evaluating the parametrial infiltration. We also explored the possibility to predict partial response in locally advanced cervical cancer patients undergoing chemoradiation and radical surgery. Recently, we tested fusion imaging technique in the assessment of locally advanced cervical cancer. So, during this long voyage, it was very important the collaboration with other European centers in Prague and in Stockholm. Nowadays, international European guidelines for the management of patients with cervical cancer included in the diagnostic workup magnetic resonance and endocavitary probe, endocavitary ultrasound examination if performed by a properly trained sonographer. The accuracy of ultrasound in detecting the lesion and in assessing the extension of the disease is similar to that provided by magnetic resonance. Cervical cancer usually appears as hypoechoic lesion growing within the cervix. Rarely, it appears isoechoic and very rarely hyperechoic. The tumor can be mainly exophytic, growing like a mushroom on the cervical surface. The tumor can be within the cervix, like in this patient. At color Doppler examination, cervical cancers are usually very well vascularized, and color Doppler helps the examiner to delineate the borders of the lesion. To define the appropriate management of a patient with cervical cancer, it's fundamental to discriminate the stage. Early stages with no infiltration of parametria are eligible for radical surgery. And if some crucial criteria are fulfilled, fertility-sparing surgery can be offered to these patients. These key parameters for fertility-sparing surgery are tumor size, distance between the tumor and the internal uterine os, and the measurement of tumor-free stroma. Tumor size has to be measured according to perpendicular axis, and the largest diameter has to be less than 2 centimeters. The distance between the cranial point of the tumor and the internal uterine os has to be more than 10 millimeters. The stromal infiltration has to be less than 2/3, and we suggest to measure this parameter cranially to the level of the vaginal fornices. Another example, here the lesion is not so big, but the distance between the tumor and the internal uterine os is less than 1 centimeter. So the diameter is a little bit more than 2 centimeters. This is less than 10 millimeters, so not all criteria are fulfilled. Cervical cancer larger than 4 centimeters infiltrating the parametra are eligible for chemoradiation. How can we assess the extension of the disease? We have to accurately assess each compartment: the ventral compartment, the posterior compartment, and the lateral compartment. In order to explain the different compartments, I will show you on the right the image of a normal cervix, and on the left, the normal, and on the right, the one case with cervical cancer. Anterior compartment. The vesicouterine septum can be simply assessed by pushing the probe against the bladder, pushing the uterus against the bladder. The normal sliding of the two organs is indicative of a normal vesicouterine septum. In this patient, the tumor infiltrates the whole stroma and infiltrates the bladder wall. How can we assess the lateral paracervix? This is the ureter, so we can rotate the probe and we can assess the tissue between the uterus and the ureter, and from the ureter till the pelvic wall. This is the crossing point between the ureter and the vessels. So this is the lateral paracervix. To assess this region, we usually do these movements. This is the longitudinal visualization of the cervix. We can rotate at the cranial level of the cervix, and we can scroll down paying attention at this hyperechoic tissue surrounding the cervix. In this patient, we can see this is the bladder, this is the cervix. During the movement, we can see a very strong fixation of the cervix to the bladder, and when rotating the probe, we can clearly assess the protrusion, the irregularities of the tissue protruding into the lateral paracervix. And other two examples of clear infiltration of the cervical cancer, creating obliteration of the ureter. Posterior compartment. Here we can see a normal rectovaginal septum and absolute normal cervix and normal retrocervix. In this patient, this is the lesion. When retracting the probe, we can see another nodule located there, documenting infiltration of the recto-vaginal septum. And whenever there is infiltration of the ureter, there is a corresponding hydronephrosis. We can also detect metastatic lymph nodes, and as we know, specificity is very high whenever we can see hypoechoic rounded lesion. The positivity, the specificity is very high. Unfortunately, sensitivity is not so high. Future perspectives, just 3 windows. The first one, fusion. I mentioned that before. Fusion simply means that we can upload the data of magnetic resonance or CT scan into the ultrasound machine, and then after synchronization we can navigate. When moving the probe, we can navigate into the magnetic resonance volume. First step is the synchronization of the techniques using anatomical markers. Second, after synchronization, we can scan, we can navigate, and we can compare the 2 images. This is a normal uterus. This is an example of very difficult cervical cancer on ultrasound because it's isoechoic. We tested 52 patients and the technique was feasible. So, another example, this is the endometrium and this is the lesion. And another example here, so this is the uterus and this is the cervix. Now I want to share with you a case of cervical cancer during pregnancy. This patient was diagnosed squamous carcinoma at 8 weeks gestation with positive lymph nodes. A careful counseling was performed with the possibility of exclusive radiotherapy and chemotherapy versus neoadjuvant chemotherapy followed by cesarean delivery and radical surgery. And the patient was strongly motivated to continue pregnancy. So she underwent laparotomic bilateral systematic lymphadenectomy. Histological examination confirmed metastasis in 11 pelvic lymph nodes and squamous carcinomas was confirmed. She underwent neoadjuvant chemotherapy, and this is the image at 24 weeks gestation, and this is the lesion at 33 weeks gestation. As always, very rich vascularization. Cesarean section was planned at 34 weeks gestation with radical hysterectomy. So just to show you, this is the view, this is the macroscopy of the uterus, and this is the localization of the cervical cancer with the confirmation of squamous carcinoma. Because of FIGO stage, greatest type, positive margins, so she also underwent radiochemotherapy. Another example, another case, in early stage cervical cancer, 37 years old patient, biopsy documented infiltrating squamous cell carcinomas. The lesion at magnetic resonance was 25 by 21 by 25 millimeters in size, located on the posterior lip. No abdominal, pelvic, nor inguinal lymphadenectomy was revealed. And I want to show you the image because not so easy to detect. In this case, the lesion was there. If we push strongly, we cannot detect this fragile tissue located on the posterior lip. Again, color Doppler examination was useful to delineate the lesion over there. So, the parameters, again, the distance, the tumor diameters, and the infiltration of the stroma. During gynecological examination under anesthesia, the exophytic lesion on the posterior cervical lip was confirmed. Parameters were not infiltrated bilaterally. The biopsy documented obtained during this procedure was, by the way, negative, but because it was taken on a different point, she underwent surgery, again radical hysterectomy, and just to show you, this was the lesion, this was the site of biopsy during examination under anesthesia, and cancer was located there. So, just to show you how is the preparation, and this is the canal, this is the vagina, so we could observe at macroscopic examination the presence of the area, the corresponding area, 28 by 17 by 11 millimeters. So this was the lesion on ultrasound, and this was the image at microscopy. So squamous cell carcinomas was documented. Just to show you one not so easy image. And what is the smallest lesion visible on ultrasound? I cannot tell you at the moment yet, but I can tell you that here on the posterior lip, this was a small lesion of 6 millimeters, and this lady underwent conization, and a lesion of 14 millimeters was observed. Now, can we move on towards the detection of small lesions? Again, in this lady, a positive biopsy was obtained, and at magnetic resonance, an exocervical lesion on the left part of the cervix of 16 millimeters was observed. And just to show you, this is absolutely not a clear lesion visible on ultrasound. We can have some suspicion here. So let's use color in this patient, and in this particular situation, color was not so strong, so we had some doubts. She underwent surgery again, and this is the macroscopic appearance. So the exocervix and the internal lesion. You remember, so little vascularization? The final histology was in cervical intraepithelial neoplasia with only isolated foci of stromal microinvasion. I want to conclude with this one. Sometimes the lesion is clearly visible, but the staging is not so easy. Here, again, a lesion of 16 millimeters. At magnetic resonance, a lesion of 3 centimeters was observed, but the key point was to differentiate the presence of any extension into the parameter. So, this is the image of the uterus, and this is the lesion. Ovaries were normal with a unilocular cyst on the left, but everything was okay. And this was the lesion. So 3 centimeters, okay. The infiltration of the whole stroma, but the difficult interpretation was regarding an eventual extension into the parameter. This is the vascularization of the lesion, so quite evident, no difficulties here. And this is the macroscopic view, so the anterior view, the posterior view, and again the lesion there. So with the infiltration of the right vaginal fornix and regarding the eventual infiltration of the parameter, it appeared to be not present. So, in conclusion, take-home messages. Cervical cancer can be examined on ultrasound. It's absolutely not difficult. In the diagnostic workup, endovaginal transrectal examination is an option if performed by properly trained examiner, and new frontiers can be explored in collaboration with the specialists of colposcopy and cervical pathology. I want to conclude with this panel of cases of cervical cancers, just to confirm, to transmit to all of you that these tumors can be visible, can be detectable on ultrasound. I thank you so much for your listening.
Thank you so much, Prof, for this great presentation. I always enjoy it, and always find it fascinating, and how to use the facility we have with ultrasound scan and how we are underusing it currently, especially in the UK. It's just a shame that we just do CT, MRI for everyone. And I always fight this, and for my own patients, I do ultrasound scan, I have to say. Now, there is a question from the audience. I have a question as well, but for the audience, I'll start with the audience. It's a question about the color score for the cervix in pregnancy and whether you still can diagnose or assess the cervical cancer with the changes in vascularity in pregnancy. Do you want to comment on that?
But we can say yes, perhaps we know that there is a physiological increase of vascularization, but as you saw in the images, usually cervical cancer is so richly vascularized. So we can imagine that during pregnancy is still more vascularized. But usually I have no difficulties in detecting vascularization. It's different for endometrial cancer. Endometrial cancer sometimes is not so easy to assess vascularization, whereas for cervical cancer, no problem.
Brilliant. Now, my question is about, I know your slides on the parametrium and how to see the ureter in the parametrium, the latter, that was great. Now, in terms of lymph nodes, for example, you still can reach the lymph nodes, pelvic lymph nodes, you assess them while doing the cervical assessment. But what about, distant staging? And how do you need, like, is there any protocol that you do an ultrasound scan, you diagnose the cervical cancer, you do the local invasive assessment in the tissue ultrasound, and then you have to assess, you have to do CT scan, you have to do MRI, or what's the protocol for your local hospital?
Yeah. But usually we perform magnetic resonance in all patients with cervical cancer. We need it because it's a panoramic view, but we are lucky because we can do that. So at the same time, we try to use also ultrasound to assess the extension of the disease. Regarding lymph nodes, Daniela Fischerova is so fantastic in visualizing small lymph nodes. I have to admit that I have some difficulties, mainly when there is an exophytic lesion. You can go transrectally to reach the iliac vessels, external and internal, but sometimes we have some difficulties. So, in summary, we always perform magnetic resonance, but we also use ultrasound in assessing the tumor and the extension of the disease.
I can see Professor Borja.
Yeah, can I just comment? I mean, obviously, this is a lot of people in low-resource settings, possibly sub-Saharan Africa, listening to this, and I think it's cervical cancers. There's an article in the BMJ, I think, quite recently saying that it's the commonest cause of death amongst women in 21 of 48 countries in sub-Saharan Africa. So clearly it's a massive issue, and I just imagine, and I'm very happy to be corrected by the audience, that MRI may be an issue in quite a lot of places.
Exactly.
So how do we, how do we translate your knowledge base and that of Ahmed's to actually teaching people to understand what's operable, not, and all the rest of it? How do we make that step to make this an accessible technique that's trained and changing the paradigm a little bit and helping to change things in some of these places?
I personally think ultrasound scan staging for cervical cancer with a CT scan, abdomen and chest and pelvis is enough.
Yeah.
But I don't know what profs think, Professor Testa.
Yeah, I fully agree with you, Matt, and I thank you so much, Tom, because when I saw, again, an organization with so many colleagues coming from different countries in Africa, I was so happy because I have a concrete experience, for instance, with a colleague from Malawi. He's dealing with so many patients with cervical cancer, and he and we all together, we can perform a correct triage of patients with cervical cancer by using ultrasound. So my answer was this is our actual situation. But if you use transvaginal ultrasound and you can detect 2 centimeters lesion, clear, no infiltration of the cervical stroma, no infiltration of parameter, you can go directly, you can perform surgery safely. If you can recognize the cancer reaching the parameter, or better, infiltrating with a dilation of the ureter, of course you have to refrain, because you can cause a damage. So you can go directly with the chemoradiation. So to me, it's an absolutely fantastic diagnostic tool and so useful in those countries.
So how, because I mean, obviously there's loads of other issues around, no doubt, HPV, HIV, and all these other things which are contributing to having high rates of cervical cancer and screening. But given the fact these cases are there and are going to continue to be there for a while, I mean, one imagines this, I'm interested to hear from the audience how ISWOG can, how can we try to make this an accessible technique that allows people to be trained so that the correct decisions can be made over management in these patients. I guess we can't answer that question now, but it's clearly something that has to, because that's, everyone talks about so many things, but this is an awful lot of women.
Yeah, and Tom, you know what? We could plan very simply, very practical webinars. Then physician colleagues, like one colleague of mine, now she's going to Madagascar and to Malawi. So an exchange, so we can go there for 1 week to teach them practically. Then we can use platform just to check after 1 month. And so very easily we can go on.
And you have things like SonoSync kind of type thing as well, which I think could be interesting.
Yeah, good.
I wanted to raise the issue because I know we've got to move on with time, and you've got your MDT. So I just thought, given the audience and everything, I think we'd be very interested to hear from the audience. What it's all very well us saying what we think, but it's obviously you, the people out there who are actually having to deal with this. Be very interested to hear back from you what we can do, and what's required, and how best you can be taught, and what we can provide. So do drop an email or drop me an email.